Well, thank you so much to those who joined us and those who joined us online. At the Academy, we're really excited to hear about the future of public health, and we have a wonderful panel. We have the Vice Dean for Public Health Practice and Community Engagement from Johns Hopkins Bloomberg School of Public Health, Joshua Sharfstein, and we have the former Deputy Director of the U.S. Centers for Disease Control and Prevention, and Schuchat, and we also have Executive Director of American Public Health Association, Georges Benjamin. So welcome to the three of you, and thank you for joining us.
Thank you.
Let's start with something very current and relevant. It's something that's in the news. There's a recent report that just came out. It's called Making Our Children Healthy Again report. It's been said by some to be one of the most transformative health documents produced by a federal government before, and that it represents more than just a single agency, but the entire cabinet. The entire president's cabinet kind of thought that this was a good report. However, there's also been some issues identified with it. So maybe you can just start by sharing, what are your thoughts on the report and what might its implications be? And we can start with you, Josh.
Great. Well, first of all, thank you so much for having me. I really appreciate this discussion and being with these great colleagues. I also would just point out that I work at Johns Hopkins, but of course I'm not speaking on behalf of Johns Hopkins. And having said that, I would start with your statement that this represents the work of different departments. I think that there was a committee of different department heads, but it's kind of unclear how this report came about. And I say that because most reports in the federal government, you can really see how reports come out. You have public meetings, you have input, you have drafts, they're circulated. This one, not so much. And of course, we found out afterwards that generative AI was used for part of it. But really, who wrote it and why, and what went into it is unclear. And I think it reads like a lot of things were thrown in there from different perspectives. Some of it is, I think, pretty interesting and provocative, like you're saying. Some of it, I think, is flat wrong and confused. And so partly, if you had a better process for coming up with an important report on child health, I think some of those things would have been sorted out, and you could see the things that were making more sense from the things that are making less sense.
Yeah, I mean, you make very good points about transparency and the process used, and then identified where there may even be some controversial issues around it. But Anne, what are your thoughts?
I think in a way, it's emblematic of a pattern that we're seeing in the administration where here's the answer, come and tell me, put some stuff together so that that's the answer. And, certainly some of the leadership in health has very strong, long-held views, whether it's vaccines or environmental toxins. And that isn't a deliberative, open, evidence-based, critical assessment. I do think, though, that, whether it's child health or all health, I think probably all three of us would feel like this is an all sector, all of government issue, and it's not just one of the departments that can put together the story. So I think the concept of bringing people together from different, from across government is good, but knowing the answer before you look into it isn't a great way to get to the best results.
I mean, you mentioned data and evidence-based, really important. Georges, what do you think?
Yeah, high school term paper that if I had a red pen, it would have got a big F with a big circle around it. So let's understand that having a report on how to improve the health of kids is not new. There are reports that come out every year and have been so for the last 40 years about how to improve the health and well-being of children in the United States. Just about every foundation that has anything around human services with kids puts out such a report. But what they all basically say is that the environment in which we grow our kids, we bring them up, has to be nurturing, has to address a range of things in the social determinant space, meaning education, transportation, childcare, safety. And while this report focused a lot on chronic disease, because that's what they said they wanted to do, the best way to have less chronic diseases is prevention in the first place. And they didn't do that. Quite frankly, they left off, even though it's not chronic disease, they left off gun violence, they left off tobacco in a meaningful way. They talked a lot about children and children's well-being. And we know that children who are traumatized early do very poorly in a range of things. But if this was an all of government response, I would have seen a lot more involvement of education, early childhood development expertise. I would have seen a lot more around how do we wrap children in places like nutrition. So they made a big deal about what's in children's food. But the biggest problem with kids is not so much what they're eating, is that they're food insecure, which is resulting in a whole range of other physiological and behavioral issues. So I think the challenge we have is the report as it was put together. And I think the transparency means it can't be trusted. And quite frankly, I've articulated that I don't believe it's of any use for policymaking or funding decisions. That doesn't mean the administration can't come up with a report that does that. In fact, there are probably 2 or 3 reports already in the department that they haven't surfaced yet that, you know, come out annually that pretty much could be used to make those decisions.
I think another point that illustrates that is there's very, very little about the importance of healthcare for kids as part of prevention. Access to healthcare, access to preventive care for their teeth, for vaccines, for helping to avoid problems that kids get all through their development. And at the same time, there are major efforts by the administration to cut back on access to healthcare, particularly for kids through Medicaid. And so it is it's frustrating to know that there are a lot of solutions for kids' health in public health, but not see them reflected in the report.
By the way, the argument from the press secretary, what this was a formatting problem. Formatting is table 1 is confused with figure 2, or the margins don't work. It's not the fact that the references were fictional and that the information in the report was just wrong. And now there are parts of the report that are probably pretty good, you know, but we haven't figured out what that is yet.
Yeah, and any parts or opportunities for the report that you'd want to highlight?
No, I mean, I think it's for an administration that really wants to foster radical transparency and gold standard science, it's not off to a great start.
Okay. Well, there you have it. Pretty harsh grade from Georges Benjamin, but perhaps one that's justified given some of the deficiencies that you've just highlighted. Let's talk about the administration and a little bit of a shift in how it's approaching things. You know, how are public health workers and administrators to navigate this new environment when it seems like the federal government is engaging differently? There would have been a different process in the past, different stakeholders involved, and obviously some different policies. But how can health officials navigate this changing environment, this changing priority that the current administration seems to have? Let's start with you, Ann.
Sure. Yeah. I mean, I think it's important. I mean, I think in public health, we are all about solving problems. And your question makes us want to jump right into the solutions. But I think it's important to acknowledge the pain and trauma and suffering that is out there right now in the public health workforce. You know, obviously there's a lot of changes going on in every sector, but people are really stunned and shocked right now at, you know, programs and individuals that were really doing incredible work to improve the nation's health that are just getting decimated. So I was often told as a leader that I jumped to the solution before, you know, stopping and acknowledging people were in a lot of pain. But I think we really have to recognize that right now. That said, the way I think about this, that the local level is much, much more important than ever. That at the national level or the federal level, you know, we need the federal level. I was part of it for 33 years, but we may not be able to count on it. And part of what's challenging in the federal level right now is a loss of trust. And I think at the local level, we have a greater capacity to rebuild trust and to maintain it. So I think for certain kinds of health issues, the emphasis on the local officials is going to be really critical.
Yeah, if I was a local health officer today, the first thing I would do is pull my staff together and say, okay, what works? What do we have? What are the resources that we have? Where are our gaps? And then I would work very hard to continue to emphasize the things that we know we do real well and for which we have the resources. And then for the things that we are under-resourced for, we have to make a tough decision about what we can do and what we can't do. And then, quite frankly, we would stop doing things that we can't do. What happens in public health far too often is we try to do it even though we know the resources out there to do it. And then sometimes we don't do it as well as we could. But as a responsible administrator, at some point you have to say enough. And this is what we can do. And of course, you have to bring in your elected leaders and the resource allocators and let them know what you can do and what you can't do and have an intelligent assessment about that. What's often not understood is that 75% of the resources at the federal level go to state and local government. So there's this sense that we're cutting the feds, we're getting rid of the bureaucracy, not realizing that that's actually what funds the local work. On average, for example, 50% of the budget of state health departments is federal money. That's a huge variance, by the way. Some get a lot more, some get a lot less. Local health departments, about 25%, partially because the states often keep a lot of the money, but also because a lot of what they do is based on fees for things that they do, restaurant inspections, perk tests for building wells. And so a lot of it's fee-based. And so they have a broader funding opportunity at the local level. But there's a huge variance there too. If you're in New York City, you get a lot more federal money than if you're some city in Oklahoma or Kansas. And so the challenge we have here is making sure that people understand that what's lost is the federal capacity to do consultation, to be a reference lab, a reference set of experts. The most visible one recently was Milwaukee, which was having a problem with lead in their schools. And they called the CDC and said, hey, we need help. And the message that came back was, can't help you, we all got fired today. Not that the folks in Milwaukee don't know how to handle an acute lead exposure, they absolutely do, but they don't have the capacity to do that long-term physical assessment, long-term risk assessment. If we had to do that in every community in the country, it would be very expensive. So like anything else, you concentrate that at the federal level where you get the world's experts to help you do it.
Yeah.
And that capacity's been lost.
Yeah, I think I'd add that what we're seeing at HHS is partly, a new agenda, and it's partly an agenda that's still getting worked out in front of us. It's kind of confusing. Sometimes I think it's a little bit confusing to them. I think the Secretary of Health and Human Services said for every 10 people that get fired, he expects that 2 of them were mistakes and that they should be brought back. Now, I've never heard that as an approach to HR before, but I think it gives you a little bit of a sense that they're not, these things are working themselves out. And it's the same for policy. They'll do one thing and then they'll hear that it's not a good idea and then they'll do something different. So I think for local and state officials, it's important to realize that the federal government is at a bit of a malleable state right now. If there are things that you need, like lead program, other things, it's important to speak to that, particularly local health departments with representatives who really have the ear of the people in power. I think there's so much the federal government does right now that is important for the health of the country, and talking about that and trying to push policy in the right direction is still something that should be on people's agenda. It shouldn't just be waiting to see how hard it's going to rain and what kind of umbrella to take out.
Yeah, I think I just wanted to react to the issue of for every 10, 2 will be a mistake. One of the groups at CDC that was let go was the in-out processing. So when they did get alerted that, we didn't mean to fire the lead people that Milwaukee needs, the people who could bring them back aren't there. So it's, I think that most of us who've worked in government would agree that there's a lot of improvements that are needed and possible. But I think that we have a pendulum situation here where if people felt government was too slow in the attempt to make it really, really fast, there's a lot of disruption that's unhealthy and that is actually dangerous. So whether we are in just a transition malleable phase right now where the federal government will get its act together, or there's a real intent to destroy it, I think is an open question.
Yeah, well, I feel compelled at least to say that, hope springs eternal, that there are some things that will overlap between the agenda, the people there, and the
Sure.
people who are responsible at the state or local level for the health of their communities. And I think people shouldn't be quiet about suggesting things. And we'll see. I think there may be areas that there's never the twain shall meet. That there's certain, as you said, fixed views that people have that are going to be hard to be compatible with good public health. But we'll see. There may be other areas. I think there, for example, the discussion of certain improvements in food have gotten a little bit of more discussion. If there's an agenda there that can overlap, then I just think this is not a moment. An instinct with all this, I'll say chaos, maybe a lot of change. Is just to like wait and try to figure out how to deal with it. But I think this is a moment to lean in and say the things that you think should be done, because I think it may not be as fixed as it can seem.
And every administrator I've ever met, since this is the Academy of Public Administration, I've always taught that you take a new job, you observe for about 6 months, figure out how the trains run and what works and what doesn't, and do an assessment, and then you make change. You don't walk in the door like a bull in the china shop and start changing things, because you will break things, and sometimes you will break things, that you can't fix. And so I think part of the problem has been the fact that many people came in making change that had no idea what they were breaking. I mean, for example, the first group of folks they let go at CDC because they were quote unquote probationary employees, not realizing that probationary may mean you've been there 15 years, but now you went to a new job. You weren't really a new hire. Or people in the Epidemiological Intelligence Service. For those of you who don't know what EIS is, they are the equivalent of the Navy SEALs for public health. They are the best disease detectives on the planet, and they let them go in the middle of a measles outbreak, I might add. So, and then all of a sudden they realize, oops, we shouldn't have done that. And then they tried to bring them back. And so I think, again, going in, being thoughtful, observing the culture, understanding what happens, and then making radical change. It's not a bad thing to do, but you have to know what you're doing up front. And frankly, they haven't done that yet.
But I think it's not really a surprise, because I think that some of the individuals just have a deep distrust of the current of the career government folks. And so I think for for public administration and for civil service, we can think about I worked for 7 different presidents and 9 different CDC directors, and was a career government employee. Wore a uniform for most of that time and really viewed myself as nonpartisan. But I think a lot of the leadership that's come in doesn't trust the current staff to take that 6-month and learn and listen. And that's just really sad, because there's enormous expertise that's very nonpartisan I think in most agencies. And I know of colleagues who had done we're going to need to cut the budget, we're going to need to reduce staff, what's the sensible what's the way to do that in a smart way, and that was not even solicited. So I just feel like that's a missed opportunity.
Yeah, I mean, you mentioned kind of some best practices towards management, which I would agree with. And then George, as you mentioned, some very serious implications if there's federal funding that flows to the local and regional entities, and that doesn't happen, that can have some severe consequences. But what are public officials to do in this case? And what's the role of other stakeholders like civil society or the broader health community?
Well, let me just say that one of the opportunities here is for civil society organizations to fill some of those gaps. Clearly, prior to there being a Department of Health and Human Services. Now, one of the benefits of being in the American Public Health Association is that we've been around for over 150 years. So we predate HHS, you know, almost all these organizations. And I know that, you know, after the Earth was formed, and then there was the American Medical Association, and then, by the way, it was APHA right after that. A lot of professional guidance came from those professional associations. And so what's going to probably happen is, as the federal government pulls back, the professional associations will then frankly have the responsibility to fill some of those gaps. We won't fill all of them, but maybe vaccine policy, maybe chronic disease policy. Organizations like the American Heart Association, American Lung Association, who have historically, you know, been evidence-based organizations, will fill a lot more gaps, and people will then turn to them more than they have historically turned to the federal government for information. We can't fill all the gap, but we will fill some of it.
Yeah. I want to go back to something, Ann, that you said, and it's a process point where you said most want to jump right to the solution. But let's spend a little bit more time on what some of the issues are. We have your all's expertise across a number of different areas. What are the major issues, and can you give some context to the things that we should be thinking about when it comes to public health right now? And Josh, why don't we start with you?
Well, we have a measles outbreak. We're the biggest one in decades. And measles is a mild disease for many people, but for a fraction of people, it can be quite severe. And we've already had, I believe, 3 deaths in the United States so far from this one. And it's very, very expensive to control. And it's totally unnecessary because it's 100% preventable if you have a high enough vaccine coverage. And we have been measles free in the United States for decades, but we could lose that designation. That is just a fact on the ground. You know, the transmission of infectious diseases is not something that a report is going to change, just the issuance of a report. You actually have to be out there fixing that. And I think that you know, funds have been cut for the response. We've had all kinds of misleading statements about the measles vaccine being made. It's an example of a very concrete problem the country's facing, that we're really at risk for having out of control measles. I'm also worried about the preparation for a potential pandemic with influenza. That is something that we learned the hard way. It's really important to be as prepared as possible for. And if the administration can't substantively have a good policy and explain it and work with people, then it creates a massive risk to the health of people all across the country, of whatever political background, you know, you could decide. I mean, the public health threats, they don't know politics, they don't know agendas, they don't know ideology, and being able to pick these and actually solve them would be the most important thing for the administration to do at this moment. And I think our biggest concern is that that's not really where their focus has been.
And what are your
So
thoughts?
since I spent my career in you know, infectious diseases and vaccines, and that's what you talked about, I think I'm going to steal yours and talk about you know, the tobacco and Office of Smoking and Health. Both the CDC and FDA groups that dealt with that leading killer of Americans are gone. And I think we've been making so much progress in terms of adult tobacco use and adult smoking. And we started to make progress in teen vaping and use of other substances. But I think we're really at risk now as the regulatory environment is changing. And those units are gone, including the smoking lab, which is like an incredible national resource. The other area I would highlight is the opioid epidemic. And on paper, we have this great improvement that, you know, the latest data is better than the year before, and we're starting finally to see reductions in deaths. But it's a very complicated epidemic. And while the idea is not to get rid of the group at CDC that was working on that, there's a general vague proposal of moving everything together in the new AHA organization. And I think there's a fear that I have that the focus really may be on treatment and not to lose the area of prevention and surveillance and response, which have been really important because this epidemic is so dynamic in terms of the factors that lead to the problems.
Yeah, the challenge we have is that we spend $5.9 trillion on healthcare in the United States each and every year. Only about 3% of that's on prevention. And of the industrialized nations of the world, we're at the bottom. And we actually know why we're at the bottom. The fact that we don't have universal health care for all of our citizens. Let's say single payer. I mean a system with everyone in and no one out. We don't have a real focus on primary care in the nation. We spend much less than other industrialized nations on the social determinants of health. Other places, during COVID, they were comparing us to Sweden, which has universal health care, universal child care, universal daycare, and everybody's covered under retirement. They could stay home if they wanted to stay home. We had people that had to go to work. We know that we have a fractured system, fractured payment system, fractured delivery system, much more so than other nations. And as a society, we have just really not made the connection between health, the economics of health, and prevention and wellness. Although, the good thing is we're excited that the administration is talking about health and wellness. It's just that talking about it is one thing, but cutting food services to the SNAP program, kicking people off of the Medicaid program, which, by the way, I ran the Medicaid program in Maryland, so I know that anytime you take $1 out of that program, somebody loses coverage. Anyone that tells you that any barrier you put in place, which they're putting lots of barriers in place, don't result in loss of coverage is wrong. Okay, that's, some things are right, some things are wrong, that's just wrong. So they will result in loss of coverage and people will lose coverage. So it's complicated. And one of the things that we've really got to do is figure out, we're serious about improving the health of Americans. We need to realize that the 10 leading causes of death are either chronic diseases or, an infection that results in a chronic disease. Even COVID, now results in a chronic disease. I think it's the 3rd or 4th leading cause of death in the country now still. Obviously injury, unintentional injuries. I think they unfunded the adult fall program. Falls is one of the leading causes of problems in hospitals in this country. So they're not really following the data. And let me finally, one more thing. During COVID, I was around for the anthrax letters and 9/11, and we were sending information by health departments by fax machine. Some of you may remember fax machines. An archaic tool we used to use to put a piece of paper in, and then something would come out the other end. During COVID, we're still using fax machines. We still can't move an EKG across the street effectively, health data effectively in our system. And yet, when I leave here, I'm going to be able to call a car to pick me up and take me back to my office and order food to meet me at the office when I get there. And I can time them at the right time. And yet our health system simply cannot still move data in an effective way. So we have not paid the attention to just the basics of a healthcare system in the country. We've got a lot of work to do.
Yeah, I mean, what would be your advice to focus more on prevention? I would imagine the current administration is serious about making sure our country is healthy as possible, and we have the systems and the data and things to ensure that. But what's missing, and what more could they be doing?
Just to build on George's comment, data are really important, and we've been pushing the modernization of data for public health for a while, with where we did finally get some resources during COVID, but they've sort of been curtailed in the middle of some of the improvement processes. But I do have fears that some of the systems by which we even know what the prevention priorities should be are endangered in terms of variables that we're not allowed to ask anymore, or we're not supposed to measure X, Y, and Z anymore, they're forbidden. It makes it hard to know how to focus when you don't have reliable data that can point to the leading causes of morbidity or mortality. Where are they occurring, in whom are they occurring? So I think that's an issue. Being female might be something we can't even measure anymore, so I just think we have to be careful about protecting the data for the long term so that we can have trends to understand that, that opioid related deaths have gone down. I'm worried that that this may be an administration where no news is good news, and are not measuring and tracking issues may lead us to detect the problems later.
You're absolutely right that the administration is talking about health in the broadest sense and has said that it cares about prevention. And I appreciate that you'll hear more about life expectancy and the needs to increase life expectancy from this secretary, for example, than we've heard in recent years. That like these are problems that the country should get behind. Once you have that overall goal, I think you have a lot of people who are going to agree with that. That is where the public health community is. It is all about improving health for the population. Then you have to decide how you're going to go about it. And this is where, public administration comes in. You have a politically set goal, but we're going to have a way to get there. And I think the challenge is, in order to do that effectively, you have to leave your ideology at the door. In public health, it's very hard to come in and say, I know the answer, and this is off the table, and we can't ask this question, or we can't do this, or we're definitely going to do this, or we know this is right and this is wrong. And because if you go down that path, you go down the path of issuing reports that haven't been vetted, haven't been gotten the contributions of people in the agencies and external to the agencies that are really expert. And where you wind up is not necessarily any place that's going to be helpful. On the other hand, if you take a step back and you say, okay, we have these goals, we've got more support from these goals all across the country, people will rally to those goals, then let's bring good data in and let's work in a non-ideological way to figure out the things that would really matter. If you were able to do that, I think that is the path to improving health in this country. What you're hearing from us is some frustration over the first 100 days, how it's played out, in arbitrary, firings, in obviously poorly planned administrative changes, in reports that, were written with generative AI and have all kinds of, issues with them. I don't think we've given up hope that this could come together, but we're at a point where it would be extremely helpful to have that overall goal be pursued in a way that's more effective.
Yeah, and I think there's a lot of, there's a lot to build on. So it can be really, it's potentially really exciting to have a health secretary who has a following, who has, and I personally think that mothers out there want their kids to be healthy. And if they're motivated and riled up and working together, a lot of good things can happen. I think this clash between the answer and the question and the how to go about it that we need to work on. So being able to harness the public in a new way is exciting, but it would be great to be harnessing the public in a way that is evidence-based and can be measurable in terms of the results that you get.
Yeah, you talk about the public, and media plays a big role in how informed the public is about public health issues, perhaps how the government may be responding to them or not. How do you think about media coverage around public health issues, and how does that coverage either hurt or help the situation? Maybe Georges, do you have an opinion first?
Yeah, there's a lot of misinformation and disinformation. Again, back when the Earth was formed and all the data and the information came from your health provider, right? We have these big books like this that we've read and we know everything in them, theoretically. And we went to people and said, this is what's wrong with you and this is what you need to do to improve your health. And people were meaningfully compliant. And then the internet came along and we democratized information. And I remember as an ER doc, I remember being in the emergency department and people would walk in with printouts from their symptoms. And they, of course, let me know what they had and sometimes even who they wanted to be referred to for their treatment and cure. Um, well, fast forward to now, we have lots of sources for people to get information. A lot of it's not good information. A lot of it's not accurate. And we've not really taught the public, public hasn't learned how to be literate in terms of how to discern good information from bad information, how to vet information, how to validate what you're reading. There is this tendency to take that information very quickly by tweet, send information. I know in COVID, I used to get misinformation from people that I trust, friends, who would send me information that they saw because it sounded good. And I would send them back a note and say, no, that's not accurate. And here's where you can go to get the right information. So the point is that the public health community, frankly, has never built the infrastructure and doesn't have the time yet to engage effectively in the way that most people get information. And we need to get better at it. We need to get in better at the 180 character response. We need to get better at podcasts and blogs and talking to people where they are to getting them good information. I think the best way to deal with bad information is to give people good information, because if we can help them figure out how to navigate it and give them good information, they will make better decisions. And I think that's the challenge I think of our generation, next several years for sure, is how to put good information in the ecosphere for people to be able to make good decisions and help them make those decisions pretty quickly, because diseases are now moving at the speed of an airplane, and we're way behind the curve on a lot of health risks that are out there.
Yeah, this is the most difficult thing there is right now. At CDC, we had a mantra of we wanted to be first, but we wanted to be right, and we wanted to be credible. And it was really hard to do all three. 20 years ago during anthrax, it was really hard to do all three, 24 years ago. But we learned how to do risk communication, so we could be first, but we acknowledged uncertainty and we avoided absolutes and we foreshadowed that things were going to change, and on and on and on. But there is no first right now. There's simultaneous information going everywhere, and people are in their own channel listening to their own, or getting their own information. And instead of first, it's either loudest or most outrageous. And it's the emotion that goes viral. It's not the trustworthy, credible information. So I think in public health and in medicine and science, we really care about accuracy, and we care about, what's the ultimate truth. And so risk communication got us to a certain extent started like, okay, we're working on it. We're going to get back to you. Here's what we know. Here's what we don't know. Here's how we're going to get more information. But we are like, in the dust by the time we finish that sentence because of how fast outrage can spread. So I really think this is the ultimately most important thing that we have to figure out how to deal with.
Yeah, well, let me just maybe add a little bit more and ask you to dig a little bit deeper, because that's around the communication piece. But Anne, you also mentioned that there's data is being treated differently. And there seems to be there would be some consequence to perhaps not having longitudinal studies, perhaps having data that used to be collected that's now not. How do you think that will impact what the public knows about what's going on in public health?
Yeah, well, I think that, we in my era of public health, we tried to get better at collecting information that would help us understand disparities. Because if you don't measure it, you don't actually know there are disparities. And if you recognize disparities, you can try to target them. But if we're not allowed to do that anymore, you wonder, we have a very diverse country. We started to look, county by county, rural, semi-rural, et cetera. And, if we can't measure the heterogeneous nature of health, it's going to be hard to see whether we're making progress.
Who can fill that gap? I mean, academia certainly does different studies on public health and puts out information as well. Josh, what do you think about that?
Well, it's a pretty big gap right now because a lot of those studies that academia does are funded by the federal government, and many of them have been ended. So I have colleagues who study, things like heart disease in the Latino population, or intimate partner violence among Black women in the South, or HIV risk among transgender individuals. And the reason they study that is because there are challenges in each of those areas, and the solutions can be identified by working with those communities to find them. And if you stop studying them, you lose the ability to have solutions, and ultimately you lose the ability to make progress on those diseases and those conditions, because you have to be able to focus on where the problem is. There's no solution that you just spread very thinly over everybody. You have to have a solution that works for populations that are actually impacted by problems. And it's one of the ironies right now, is that the administration talks about chronic disease but doesn't want to talk about the populations that suffer from chronic disease, and what the different barriers they have to get access to healthy food or other critical determinants of health. Um, can the private sector make up for some of this? I think they can do some, but a lot has already been lost here. And I think you see a little bit of an inkling, because there are some leaders in this administration who say things like, well, of course we have to look at disparities, even though they are defunding studies on disparities. And I hope that this is one of the ships that they can right and come to an understanding that things that they may consider preferential treatment, for example, they're going to have their position on that, but that's not what equity is about. That's not what looking at disparities is about. That's a very, very fundamentally different thing when it comes to health. And I'm hopeful that, or at least I can imagine that they could find themselves to a different place where we are again working together to understand the differences in health and what can be done to fix it.
Yeah, and we've covered a number of issues. You talked a little bit about health equity, talked about tobacco use, opioid issues, Medicaid. One of the things that I want to come back to is about vaccinations. It shouldn't really be a major issue, but certainly is a current one and seems to be fairly contentious. Can you talk a little bit about the current vaccination policy and perhaps compare that to what was in the previous administration and what some of that change's impact might be? Maybe Anne, we'll start with you, and then George's, why don't you go after Anne?
Yeah, there's a long-term committee at the CDC that has made recommendations for civilian use of vaccines that after the FDA has approved them. And it has a process that has evolved over the decades to what we thought was a very deliberate, evidence-informed, transparent process by which the data were reviewed in public stakeholders had a chance to make comments, and recommendations were made using a structured evidence to recommendation format. That just got thrown out of the window with the latest COVID recommendations, like a week after the secretary told Congress that no one should take medical advice from him, he released a brief TikTok message of here's what you should do with COVID vaccine this year. So that was just a shock. Hopefully it was a one-time shock. It's unclear what was the big rush, in terms of making that TikTok. But the hope, I guess my hope, is that this very deliberative process that people can can participate in, can observe, that doesn't have smoke-filled rooms, where there aren't conflicts of interest, and the holdings of the members of the committee are disclosed, that can go on. It's really, I think, a model system for the world. So it would be a shame if it's completely ignored. I think we're going to have to see what happens in a couple weeks when the next meeting of that group occurs. But the COVID recommendation from the secretary really came out of the blue and was very confusing, since it contradicted what his FDA commissioner had just published pretty much the same day.
Great. Before I ask my last question, I know we have many people joining us online, but we do have people here with us, and I'll ask if anyone has any questions for our distinguished panel.
I'll go ahead and just ask one. I know, George, you brought up about that organizations might kind of have to step in to fill the gap from the federal government. But what do you say, or what would you say about potential hesitancy to fill that gap? Because there's a perception that anything that you say is suddenly partisan and against the administration. So ultimately what I'm getting at is, can they fill that void, or are they making themselves targets?
Yeah, one of the really big issues around authoritarian regimes is pushing out anticipatory obedience. And I grew up in Chicago, and I know bullies. And quite frankly, there are some people in the administration acting like bullies. And if you want to give me your power, be my guest, but it only gets worse. And so I have been real clear that, at least at the American Public Health Association, we're going to be evidence-based, we're going to speak our values, and we're going to ignore anticipatory obedience. So as an example, when they came out and said diversity, equity, and inclusion was wrong and was discriminatory, we pointed out that that's not true. That's a redefinition of what it is, and we're not going to abide by it. And we haven't. And I'm sure at some point they will come after us. But I'm willing to take on that fight, because as an African American man, I remember there's something called the 13th, 14th, and 15th Amendments, and a few other amendments out there that guarantee me the right those freedoms. We have a First Amendment as well. So we're not going to run for those things. Now, we might decide to redefine DEI as IED, so they won't know what we're talking about. But honestly, we felt it was important for us to maintain our core values.
I might also point out that there are many parts of public health that have vast levels of support in the public. And so if there's something that the federal government can't do, like address lead or help with the measles outbreak response, population wants to stop lead poisoning and does not want a huge measles outbreak. And so there are plenty of ways for many people to be involved in the work of public health and really meet the needs of the population, that I don't think it's realistic to think that they would get targeted for doing things that are that popular.
I think about your thoughts on implications for the public health workforce at the various levels, federal, state, local. So
Just to jump in and say, the public health workforce at the federal level has had a miserable 100+ days here. And frankly, they were treated inhumanely in many cases. People showing up after years of work, finding out whether they're fired by whether they badge in or out. You can have whatever position you want to have, but that's not some way to treat someone. I think that after administrations, both Democratic and Republican, talked about how important it is to have a qualified, nonpartisan, respected expert workforce, there were campaigns under the Bush administration, under the first Trump administration, to make people feel valued. What happened here is really just astonishingly terrible, and I think it is going to take a long time for people to build back confidence that they'll be supported, and we'll all be paying the price for that for many years. I think the state and local, it's a different story. You know, they haven't experienced that level of cruelty, and I think they're at this point feeling that a lot is on their shoulders. And I've talked to many people at the state and local level who are seeing what's happening at the federal level and saying, well, you know, someone might not be in the other end of the phone, so where are we going to find expertise? Let's reach out to our academic partners. Let's figure out what we can do with each other. Let's share data in different ways. And so in a somewhat paradoxical way, I think states and localities are getting, you know, feeling like this may be their moment. And I hope that leaders, Democratic and Republican, are going to be supporting that workforce, because frankly, they're going to be needed more than ever. The breakdowns that are we're starting to see are going to have consequences, and that those teams are going to be on the front lines.
And I think that people don't really get into public health because it's a high-paid, glamorous profession. You know, I think you know, people are used to working hard on really difficult issues. And there's a lot of difficult issues now. And so I think that whether the jobs will be there for the future workforce, I'm not sure, the same jobs will be there, but I think the work is really going to be needed, and people will find a way to get that meaning. That is why most of us went into public health.
Let's take one more question before I ask my final one. Go ahead.
Thank you for this. It was just a great discussion. I'm just curious if you can reflect on who actually benefits from some of the decisions that are made. We know that a lot of people will be harmed from decisions with respect to vaccines, tobacco, data, not being available to really look at what's going on. But can you speculate on what this is good for? Who is it good for? What is it good for in terms of some stated goals?
You have to, I think, understand what the goal here is. The goal here is to get money to do a big tax cut. That's the purpose of all this.
Okay.
All of this is designed to get money so that they can do a big tax cut. Now, you can argue about whether or not what population is going to get that money. But that's all what this is designed to do. I mean, right now they are planning on slowing the spending. So at the end of the year, this current fiscal year, they can do a big precision of the existing funding. Everything they've done has been to get money to support the tax cut. And they haven't cared how they do it. Now, there is a big philosophical issue happening too, which conservatives have been trying to do for years, is dramatically reduce the size of government. So that is the overarching goal in many ways. I don't think anyone's been happy with the way it's happened because it's been painful. But I think at the end of the day, it's achieving a goal to downsize government, cut that spending. And if that money was being recycled into social supports for people and more programming in an intelligent way, I think, not the way they did it, but I think there'd be a lot of support for moving some of the money around in more productive ways. But if you look at what they're actually trying to do, they're trying to permanently downsize spending in government. And it's right in front of us. They're going to do a big tax cut, which will then ultimately, and it's going to be permanent now, it's going to prevent the rebuilding of any of this, because the revenue is not going to be there unless a new Congress comes along and the president decides to increase taxes dramatically in order to balance the books. That's what's happening. And it's hurting a lot of people along the way.
I would just say it's going to be important to follow the money, because there's a lot of money the federal government does put out, and where that winds up going could partly answer your question. In the past, when there have been campaigns organized against vaccines, some of the people who've been involved have been selling alternative treatments, some of them quite dangerous. And so, I come with having lived through that era with a healthy dose of cynicism about people who are saying things that aren't true about vaccines and other treatments, whether there's an ulterior motive. We'll have to see. But I think there's reason for suspicion.
And let's go online and take one question online.
Okay, hopefully this works. If not, I'll just project. We got a couple different questions online, but I'm just going to give you one. Kind of going off of what you all have been talking about, how can experienced public health professionals help to counteract the confusion that's happening with the public when they're faced with guidance that lacks a strong evidence base?
I think let's start with impact. So we know a lot of things are happening because of cuts, because of people losing their jobs. I think we have to tell those stories. One of the challenges in public health is we always try to make it up and tighten our belts and solve the problem. You still need to take care of people, but I do think we need to do a better job of articulating the impact at the local level. And that means telling any elected official that will listen what those impacts are. Because public health does is when we do our best work, nothing happens. We're so silent and so invisible that it's not until something bad happens that people get concerned. So I think the first thing to do is talk to the impact and real impacts. Let's not be hysterical. Let's not overstate tell people the truth, and tell them what they can really say.
Yeah, I think a lot of the experienced public health folks feel like, well, I'm experienced, but I'm not really an expert and, I can't speak to that. But I think this is a friend of mine called this a 5-alarm fire moment in terms of the threats out there that really will have terrible consequences for people in cities, towns, and we didn't even get to the global situation. And so I do think that telling one, sharing one's expertise, particularly to those in your communities can be really important. I think a lot of people who are still in the workforce feel nervous about that and worried about their jobs, but the retired workforce or the general public workforce can use their voice.
Yeah, I would just add that, as Ann said, there's the traditional playbook of the public health communicator who is speaking from evidence. And the world has changed a lot since then, like she said. And I would recommend that people who are looking to fill gaps, fill them as a team. Find other people to work with, and they don't necessarily all have to be from within public health. You could have, a nurse, a teacher, a business leader, a faith leader, all talking about the value that vaccines bring to a particular community. It doesn't just have to be the public health voice. And by doing that, you're countering some of the chaos online with people that are known and with voices that have been heard before and with messages that people can trust.
All really good points and advice here. Let's end with 5 seconds of inspiration. Let's assume that we all want our country to be healthier. We want future generations to inherit a system that's based on data and evidence and has the funding and the mechanisms to ensure that they're healthy as well. What is your 5-second inspirational thought on how to help public health workers, how to help the current administration in this moment right now? We'll start with you, Josh, then go with you, Ann, and then you, Georgia.
I'd say if we can lay down our ideology and focus on the experience that people have and the evidence of what can improve health, there's plenty of room for a common agenda in this country.
Yeah, I would just say to take the long view. I can look back over the 30-some years I was in public health and see the transformation of lives in this country and around the world. And I think we have the same, enormous potential in the next few decades. So this is a tough moment, but it's an incredible discipline, and stick with it if you're in it.
Yeah, achieving optimal health is an admirable goal, and at least the American Public Health Association, we're here to help the American people and this administration achieve that goal. We're just down the street. They know my number. They know Josh's number. They certainly know how to get a hold of Ann. If they want to find out how to do some of these things and how to engage effectively, we're here to help.
What a phenomenal panel with a lot of information and insights to share. I want to thank the three of you. We're joined here with Executive Director from American Public Health Association, Georges Benjamin, former Deputy Director at U.S. Centers for Disease Control and Prevention, Ann Schuchat, and Vice Dean for Public Health Practice and Community Engagement at Johns Hopkins Bloomberg School of Public Health, however, in his own capacity, Joshua Sharfstein. Thank you so much for joining us today.
Thank you.
Thank you.